Hi, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Experts series, we have one of the leading myeloma experts from the country, Dr. Attaya Suvannasankha, who is professor of medicine at Indiana University, one of the larger and more esteemed myeloma centers in the country. So she gave a talk at the ASCO meeting, educating the physicians about the role of bispecifics as they move into earlier lines. And her topic specifically was for first line treatment. So, welcome, Ataya. It's a pleasure to have you here.
It really is a privilege. Thank you very much for the opportunity to really talk about exciting technology we have, but also to share what I presented at our most recent international meeting, the ASCO meeting, really in Chicago just a little bit earlier. So I was tasked with this exactly interesting topic. Are we ready to move this new technology to upfront therapy in myeloma? So, as you know, these bispecific antibodies or innovative immune therapy, they have actually been approved just in this past few years, and we have 3 products. Actually, the slide needs to be updated because
Yeah,
linvoseltamab just got approved.
correct.
So linvoseltamab is another BCMA bispecific antibody and just got approved less than 2 weeks ago. So this slide is already outdated, but so we have 3 BCMA bispecific antibodies and one that is a non-BCMA bispecific antibody, and that is talquetamab, which binds onto GPRC5D. This table is just showing their promise in patients who are relapse refractory disease. That means that they have failed at least 3 prior lines of therapy, including classic anti-myeloma agent, your immune modulatory agent, proteasome inhibitor, CD38 antibodies, and the efficacy across the board was very, very good. So it was life-saving for patients in that late line relapse. So of course, we're not saving the best for last. We're myeloma doctor. We want the best first. So the question then is, where should it fit? And
So,
there are
what about the side effect profile before we move on to moving it earlier?
That is important. As we're all excited about the efficacy, we must also talk about how to keep people well when they're on this class of drugs. So they do, as a whole B class, have unique immune-mediated side effects. And that is really at the start of the treatment when we're engaging the T cells and let those T cells start to look for the enemy, and that's the cancer cells. We start to cause immune reaction. When I think about T cells like killing off things that don't belong to us, when we fight a flu, you get fever, achiness, chills. Well, when the T cells are engaging with the tumor cells, it's kind of causing that similar symptoms. Unfortunately, though, in some patients, that can be a pretty high-grade fever causing a change in the blood pressure, a change in oxygen. In addition, there's also some nervous system side effects. Some patients would have confusion, increased risk of seizure, for example. We learned that the same things happened also with another T cell therapy called CAR T cell. The incidence, the frequency of these happening with antibodies a little less, but fever across the board is pretty common. Probably nearly 2/3 of patients would have that, and luckily smaller number of people will have the need for extra management to cool down the immune system. Now, that's the story of early part of the treatment. Once patients get past the first few weeks, they're not going to have these ongoing side effects. However, ongoing risk with using these agents or in fact infection. When we clear out the plasma cells, the cancerous plasma cells, the myeloma cells, we also clear out lots of normal plasma cells. So our patients will have low antibody level, increasing risk of infection. They need to be on antibiotic prophylaxis and also replacement of the antibody, this infusion of immunoglobulin. Something to keep in mind also is talquetamab, which binds onto that GPRC5D, has another unique set of side effects. The GPRC5D happen to also be present in the skin and also on the surface of the tongue. So people can have burning sensation in their tongue, loss of taste. They can have the skin dryness and nail change. The nails become kind of rough, deformed. Some people lose their nails. So with promise come with concerns. About a third of patients actually have pretty significant infection. The grade 3, 4 infection that's reported here represent the group that require typically intravenous antibiotics or even hospitalization.
So, do these drugs work forever in the situation they're currently used?
So in relapse refractory setting, doesn't work forever. So first, it doesn't work in 100% of people. Unfortunately, even when the targets are present, efficacy is really about 60%, 70%. And the progression-free survival, which is sort of the time that people continue to respond to therapy, is projected to be a year and a half, depending on different studies. So while this is a group of patients that before this class of drug became available, they might not have had overall lifespan that's passing 9 months to a year. Now they're living past that, but the duration of response continues to be an issue here. Eventually, the cancer cells are sneaky. They found a way to get around the immune system. So the slide that you kindly show here was what we think about when we think about this group of drug and why it may not work. So if I think about this drug as employing the T cells, my soldiers, to go fight the enemy, which is the cancer cells, then the fight only works if my soldiers are any good. So while we look at the T cells themselves in the way of the number, the function, how fit they are, we know that if we chronically activating the T cells, we may get them into trouble. They're less fit. But also T cells in patients who have been through multiple lines of therapy may also lose their own fitness. So that's a problem. On the other hand, the cancer cells themselves are sneaky. They can decrease expression of the target. They can mutate it, make the molecule not able to bind onto the target anymore, or they can also turn on other internal switches to make the T cell not able to, even when the T cells see them, they cannot attack the tumor cells. Where the tumor cells live, they don't live in the petri dish. They actually live inside the bone marrow or inside the tumor tissue. In that area, in the battlefield, the battlefield itself can also be helping the cancer more than our T cells. So this is really highlighting the many different ways that the treatment may run into trouble.
So, what is the rationale for moving them up front?
So the whole idea is because we realize that there are some limitations in what these kind of technology can do. So if I think about where would they fit best? So if I want the best soldiers, the best T cells, where would that be? Well, it would have to be before the T cells are actually beaten up by prior treatments. And that's perhaps upfront therapy. The T cells are going to be more robust. How about on the cancer cell? They're less likely to be able to already cause mutation or downregulation of that target. In addition to that, those tumor cells are hopefully a little less refractory, might actually be a little bit easier to fight off the enemy first time around and do the right thing. When what we learn in myeloma is it's always harder to treat the cancer that comes back. If you do the right thing by using the best tool up front, hopefully, even if the cancer cells would come back, hopefully it's a long time from now. In addition to that, we have other tools that are already available in earlier lines. These other tools have already been shown to potentially be helping the bispecific antibody. So there are various combinations that are now being looked at in earlier lines in people who have been failing at least one line of therapy, for example. Wouldn't they also be even better to move up, to be used before someone failed anything at all? Now, when I think about this line of therapy, I think we also need to keep in mind that every time someone progresses on a therapy, their health may not be the same. There's something called attrition rate. What it means is just that if I have 100 patients and I'm saving my good therapy for later, every time that someone progresses, I want to lose some. Some might become too frail. Some may actually have complication from their cancer. They may not go on to receive the next line of therapy. If we want most number of people to get the best care, then we got to actually use it early. There is a specific group of patients that are most concerning, and they are the high risk subgroup. These are people who today, with great choices we have, we don't believe that we can make their cancer respond as well as people who don't have these high risk markers, such as normal genetic markers, for example, or people with advanced stage disease. These don't seem to be as critical when we employ immune therapy. So if we want to help this group of people the most, they're probably also the people who can benefit from using this technology early.
So what is the data? I guess we'll start with the transplant eligible population first.
So, in our kind of line of thinking, whenever we see patients, we're still thinking about them as, is this someone who's eligible for stem cell transplant, or is this someone who's more frail or older, or maybe not as fit to be able to do transplant? But I think as we talk through some of these strategies, it might become a little bit blendy in that it very well may be that we're trying to treat as many people as possible, no matter whether they're transplant eligible or not. But the group of studies that are enrolling patients who are transplant eligible are and these are just some examples. There's so many more that are very, very early in their development. But the Majestic 5 is a study that is using teclistamab and talquetamab based combinations in patients who are transplant eligible, newly diagnosed. And this is very early data. They're looking at running parallel multiple doses at once to really try to get a sense for where do we go from here to a larger cohort of patients. So teclistamab was explored together with daratumumab and lenalidomide, and it is with the schedule of once a week or every 4 weeks. And also the daratumumab, bortezomib, lenalidomide, and teclistamab, literally combining all of the best we have all together in the arm B. And you'll see that this is actually very early data. We know that response to this group of drugs improve over time. But even with this early data that was just presented last December, so we're 6 months from that data now, you'll see that the rate of stringent complete remission is extraordinary. It's knocking on 100% all across. It's just a matter of whether it's going to continue to improve over time. But the endpoint that's worth thinking about is in people who have completed 3 cycles of therapy. There are only 35 patients out of the overall 49 that have completed at least 3 cycles, and they're 100% MRD negative. So, I mean, I think when I look at the table on top, it's also important to remember that, well, but only 35 patients actually completed 3 cycles. So this is actually 3 cycles and less in good bulk of them, and they're already in that tremendously deep remission. But then when we use so much treatment upfront, there's always a concern, well, can you collect the stem cells? And in this group of patients, robust number of stem cells were obtained. The safety signal didn't seem to be hugely significant comparing to when these agents were used alone in the late lines. Now, the difference very well may be that we're talking about the fitter group because they have just been diagnosed. They haven't actually been through so much. So I think early data, but super exciting.
Certainly, and it will be great to see what the MRD negativity rates are over here.
Right. Yeah. I mean, 35 out of 35 so far. So these are just examples of other studies. The GEM-TICTAL is a phase 2 that's evaluating TICDARA versus TALDARA in a high-risk newly diagnosed myeloma. So of course, this is the group that we're worried about the most. And it almost like really giving a different sense for how studies are done because this is actually offering without transplant. So the question then is transplant still needed? Because you and I were just excited about that MRD data. If everyone could achieve such deep remission, could we replace, do we still need transplant, and in whom might we need it? So this is using DARA VRD as a standard induction therapy and then intensify with TEC-DARA or tau-DARA based on the MRD status. So if people are MRD positive after the standard induction, then they go on to the intensification, and then they're going on to maintenance therapy. Patients were allowed to have their stem cells collected, so they could still consider stem cell transplant down the road, but it isn't part of the induction consolidation as we do in the standard approach today. So to me, this is sort of challenging the paradigm of the transplant. It's using MRD to guide who needs the intensification with the bispecific antibody, and also people who are MRD positive who are not cleared, they can go to salvage therapy, which may include transplant. But if they're MRD negative, then they just stay on the maintenance therapy. So I think this is really starting to combine the high risk group together. And they may or may not need to be transplant eligible or ineligible when they get enrolled anymore.
So let's switch to the truly transplant ineligible group. So what do we know about the ongoing trials in this population?
So we always are worried about the transplant ineligible because classically, this is a group of patients that whenever we had new drugs, this is the group that tends to kind of like be left behind for a minute because there's always a concern whether they're going to be able to sustain the intensity of therapy and so on. So what's unique, I think, about bispecific antibody is because it's so specific to the tumor cells, doesn't actually cause a whole lot of off-target side effects aside from the concern for infection and the initial immune-related side effects. So the question then is, can it be used successfully in people who are older, who are more frail? So this is an example of the MajesTEC-7 study, which is a randomized phase 3 study that's using teclistamab daralen versus talquetamab daralen and versus the daratumumab lenalidomide dexamethasone, and that's a classic regimen for the so-called transplant ineligible population. So the study is supposed to be a 1-to-1-to-1 randomization. But the data that came out is actually what I think is making the clinical trial design in myeloma today an interesting one, because we don't actually have the comparative data, but they have this part of the study that's called the safety run-in cohort. What does it mean? It just means that before you actually go to large number of patients and start to randomize them, this is to give a flavor, give a taste for in limited number of patients if we're who are transplant ineligible who are going to get treated this way. What is the early data going to look like? This is just from the 26 patients in the cohort 1, so that's teclistamab, daratumumab, and lenalidomide, and patients have had median follow-up of about 13.8 months now. Overall response rate was 92.3%, so stellar. The concern, though, is on the side effect side. We're still seeing infection, some cytopenia, definitely low antibodies and hypogammaglobulinemia, some GI side effects, and of course, the cytokine release syndrome signal is there. Luckily, most of the grading of these side effects are actually grade 1 and 2. The infection that's grade 3, which still continues to need to be followed in larger group of patients. But I find that what's interesting, Ravi, is that we used to do phase 1 study. And then after we figure out the dose, then we go to the phase 2 where we're asking a question, does something work in larger number of patients? And then based on that data, we design phase 3 study, which is now asking about, can this drug really prove itself to be better than the standard of care? And that leads to approval. So now we're actually having phase 3 study that is sort of having a minor phase 1-2 built into it. And I think that this may be a clever way to get to approval faster, because we can then get this safety signal and be able to modify right within while we're still trying to get to that randomization. And hopefully, before we are expanding to too many patients, we're already able to modify some game plan to be sure that we're not hurting people, but also that we're efficient in getting drugs to as many people as possible. Because, of course, we're no longer in an era where we need to wait 5 years, 8 years. We're really trying to get regimens move forward faster. So I think it's an interesting time.
Surely. And what about the other BCMA bispecific that you mentioned? What's going on with elranatamab?
So elranatamab also has a phase 3 data that was just presented at the same meeting that I presented in the education session. So if anyone's interested, Dr. Kwok also has a presentation that has more of the nitty-gritty details of the study that was presented. This study is called Magnetism MM6, and it was a phase 3 data, a phase 2 study that was randomizing patients to receive elranatamab together with lenalidomide with or without daratumumab, comparing to DARA, lenalidomide, dexamethasone, and that's the same control arm in the other study, the Majestic 7 that we looked at. And this is all in transplant ineligible patients. This is again initial results from 37 patients, and these 37 patients were kind of like that, the safety run-in population before it goes to the full phase 3. So 91%, 91.9% overall response with 81%. That's very good partial remission or higher. And this is really, almost 96% in patients who had at least 4 months of follow-up. CRS ICANS rate, I think, is relatively similar to what we have seen in the relapse refractory setting. People are always worried when we're activating the T cells that are more fit. Are we going to see more of those immune side effects? Granted, the numbers of patients in both of these studies are small, but it seemed that that immune side effect did not seem to increase too much. I think infection, though, is something that we will need to keep an eye on because it tends to still be an ongoing risk the longer we keep people on treatment. And right now, we're reporting data that are from patients who have not been on treatment for so long. So right now, 18.9%, it doesn't look bad, but if we keep people on treatment for a longer time, are we going to run into a problem or not? That I think we need to see.
So, what are your key takeaways from the data so far, and where do you think the field is moving?
So I think, of course, we're most excited about moving good technology to help as many people as possible. But until the drug's approved, something to keep in mind, it is already approved in relapse refractory multiple myeloma. It is disappointing to see that a good number of myeloma patients actually died in this past 2 years since the drugs have been approved without having a chance to be exposed to receive the treatment. So being able to think about using it in that way, but also think about using it even earlier, particularly in high-risk population on clinical trial, refer patients if they are, if these agents or these clinical trials are not available in your center would be important. But I also think that ongoing utilization of these agents are going to require quite a bit of supportive care. It's not a one and done. So we need to be mindful about the infection. Hold the drug if someone is having concern for infection, prevent it, IVIG, antimicrobial prophylaxis, vaccines, you name it. And I think general infection precaution when the season hits, flu, viral season, mask would probably still be something that we can simply do with such low cost. Where do research go? I'm excited about seeing this phase 3 study coming on fast and furious because I think if we need to wait for one stage at a time, then we're just going to have to wait that much longer. I am super excited to see the MRD becoming not just a way to mark success, but a tool to tell us how to personalize therapy, to use it in intensification in people who don't achieve endpoint we need, but also to be able to give people who are already having really good response a possibility to be able to back off from therapy. So I think optimizing the duration, the intensity of the therapy should hopefully also help us when we think about infection side effects. Now, we don't know about long-term side effects when we use these agents in frontline. Even in relapse refractory setting, the agents have only been around for not so many years. So there's a concern about down the road, what does T-cell exhaustion really mean to subsequent lines of therapy? And also, we saw CAR T and some concern about T-cell malignancy, about other cancers turning on. So we probably won't have T-cell malignancy because we don't deal with the genetically and engineered T cells, but we need to worry about other cancers down the road. I think we're advancing care, but also at such huge price. So the question then is about the financial toxicity. Who can afford this agent? I think in a way, if we use the right duration and be able to customize the treatment for each patient based on their response, that will help us with financial toxicity. I think expanding access is going to be important because, you know, the more people we're trying to give these drugs to on clinical trial, when clinical trials are still being done at academic center, how do we meet people where they live? And I'm hoping that patients who may come across this podcast, this lecture would also be their own self-advocate. I think we're in it together. I think patients can totally join patient support group, speak up to their doctor about the interest in modern technology, be sure that their doctors are working together with the larger center. Myeloma care changed so much so fast. Even these lights become obsolete because 2 weeks ago we got new drugs. So we are in it together, and I think patient empowerment is going to be key. But also, we're so privileged to be practicing where things are happening. But myeloma is a global disease. Um, it's important to also, I think, speaks to being sure that these are being explored in other parts of the world as well. So that's really where I think we're at, and so much to look forward to.
Well, I really thank you very much for sharing this exciting data. Obviously, this field is in its infancy, and there's obviously a lot to come. And I hope I can have you back to tell us as more of this data becomes available in the years to come.
Thank you very much. You and I can retire to a good island when we cure all everybody.
We're looking forward to that day. Thank you.
Take care.